Now another person from Coimbatore, Dr. Prem Krishna from same PSG hospital. So how imaging saved the catastrophe?
Good afternoon. On behalf of TCT, I'll be presenting this OCT guided left main LED PCI. Because of the use of imaging, I managed to save a catastrophe. So this is a simple case. A 40-year-old male smoker, antiretroviral MI, who was thrombolyzed with streptokinase. Because of post-infarction angina, he was referred for further management. EF showed an LAD territory hypokinesia with an ECHO showed an LAD territory hypokinesia with an EF of 45%. So this is the routine angiogram, which shows a tight proximal LAD lesion. So, and this is the PA cranial view, which again shows a proximal LAD lesion. So nothing much to say about this. I just planned for a routine ad hoc PCI. So this is the 6 French XB LAD guide. So I did a pre-dilatation with the 3x10 NC balloon, and then took a 3.5 into 33 millimeter Zions expedition stent. That was deployed at 12 atmospheres and post-dilated with a 3.5 NC at 20 atmospheres. So everything went on well until now. So this was okay. Everything was a straightforward PCI. Stent boost was also showed a good stent expansion. And just as I was about to remove the wire, I just noticed something. This is, you can see here, this is the routine initial coronary angiogram, which shows this is the PA caudal view. There's nothing much here you can see. It's just a proximal LAD lesion. But this was the same view post PCA, post dilatation. As I was just about to remove the wire, I just noticed something here. Can you just focus here on the left? Sort of indentation. Okay, initially it didn't appear much. I just thought anyway, just before removing the wire, we'll just do an OCT and see. So this was the OCT of the LAD stent. So the distal expansion, distal edge, there's no edge dissection. Stent appears well expanded. There's no malapposition, and there's a lot of fibrous plaque there. But still, I would able to achieve a good expansion percentage of 105%. So nothing much to say with the LAD stent. So as I was coming proximally into the left main area, this was just the initial run. So this showed there's some amount of red mark. That is because of the eccentric expansion there in the LAD. That's not possible to oppose that segment because of the eccentric lumen. So then what I did is I then again took a 3.75 balloon, post-dilated it again, and then did a OCT run here. And this LAD stent appears okay. That proximal under expansion was okay. Now, as you, this is the same proximal LAD which was under expanded previously. Now there shows some good opposition. So as you notice the OCT slowly, if you can see when the OCT comes into the left main area, just watch here. Yeah, now you can see as it comes here, yeah, there's a huge dissection here in the left main area, something like an outpouching here. So that was one which was visible in the initial, the last angiographic view. So subsequently, what this OCT showed was it's either a dissection, probably a guide induced, or an OCT catheter induced, or a balloon induced, or it was a focal left main diverticulum. So I didn't want to leave that. So what I did, I just tented the left main to LAD with the crossover 4 into 12 mm onyx with a post-dilated with a 4.5 into 8 NC balloon, and the final result was okay. So this is the final OCT run, just to show the left main area. Yeah, so this is that left main dissection which was sealed now. So there's no further. This is the dissection. It's intra stents now. So subsequently, the proximal edges were clean. So this is how imaging helped us a lot, because it's just a simple type A angioplasty. If I wouldn't have noticed that focal out thing in the PA caudal view, and if I wouldn't have had an imaging, probably we would have just come out like that, and that would have landed up in deep trouble. So edge dissections can be either intimal, medial, or adventitial. So when we are supposed to treat them as per the Illumin 3 criteria, is if the dissection angle is more than 60 and length is more than 3 millimeters, and if the residual lumen area is less than 90, then we are supposed to call them as a major dissection and we have to address them. So any flow limiting, angiographically flow compromising dissection, if the reference vessel diameter is also small, and if there's a large free floating trap, then these OCT detected dissections needed to be treated. So thank you.
So thank you, Dr. KP, for that wonderful presentation. Nice OCT images, excellent OCT images. Now, my question is, now, what do you think was the cause of this? You gave a couple of options and you use the word edge dissection. So both are not compliant to each other. If you say edge dissection, that means it is related to your stent placement and edge dissection at the stent. But I thought there was a gap between the stent placement and the dissection which you could see there, which was in the left main. So if it is guide catheter induced, or if it is, as you said, OCT catheter or one of the balloons, especially when you use some Oxford balloons, high profile balloons, when they go through the roof, they may scrape it and cause such kind of dissection. But otherwise, if it is an edge dissection, which is short and proximal, meeting the criteria of all the three, and plus the fourth one not extending up to the media, could have been left alone also. But if this is guide catheter or any dissection which is iatrogenic due to device crossing, then of course it has to be sealed. So what do you think was the cause of dissection? I think there was a gap between the stent and the dissection. So I thought this was device induced.